in India. The incidence is increasing almost according to the 2024 ICMR data. We have Acinetobacter, which is having almost 88% resistant to carbapenems, and Klebsiella, which is almost 50% resistant to carbapenems, Pseudomonas around 30%. So in that way, definitely learning about the carbapenems resistance is very important for us. In that, again, metallo-beta-lactamase, which is most common in India, usually it will come along with serine proteinases type of resistance to the carbapenems. So let us know more in detail about this metallo-beta-lactamase, and then what are the new antibiotics which are in pipeline for that. So to know about that, we have our guest speaker, Professor Garyfallia Poulakou. She is from National University Athens. She has accomplished her infectious disease fellowship in critically ill patients, and she is also a co-chair and vice chair for European Society of Clinical Microbiology in Infectious Diseases International Study Group. She had a lot of publications, around 225 publications in her name, as a author and co-author also. And she is currently working in preparing guidelines for antimicrobial stewardship in European Society of Intensive Care Medicine. She had done a research in anakinra for COVID, which had got FDA approval also for that. So to listen more about that, we welcome you, ma'am. Over to you, ma'am. Yeah.
Thank you very much for the warm introduction. I'm indeed very happy to be here with you. It's my first time in India and my second city that I visit. Okay. Okay, we'll be waiting. So could I ask, please, to raise hands who among you are intensivists? Okay. Internal medicine? No. Nurses? Good. Surgeons? Yes. ID physician, yes, I met him. That's why I didn't ask. Emergency physician? Oh, yes. Good. And gastroenterologist?
Surgical oncologist.
Fantastic. Well, it is a mixed population, audience. First, I must say that I was impressed by your facilities and the kind round that we did with your chief. It was really impressive. It's a new hospital, very, very clean, very, very well organized. I'm very happy for you, and I hope you have good results with your patients.
We are 13-year-old also.
Mm-hmm. Okay. Let's start then. These are my disclosures for this presentation. And I will start with the description of the main beta-lactamases. Beta-lactams are one of the most important classes of antibiotics because they are life-saving and they have good results in terms of eradicating the pathogen and the final outcome for the patient. Over the years, there are many enzymes that are produced by bacteria in order to deactivate this valuable class of antibiotics. The Ambler classification is probably the most popular and makes the distinction between class A, the serine beta-lactamases, class C, which is mainly cephalosporinases, and class D, which is oxacillinases. You can see in yellow the products of these classes that are deactivating penicillins. On the other hand, we have more specified beta-lactamases that deactivate second, third, and fourth generation cephalosporins. These are marked with blue, but they all belong in those three classes. The fourth and currently the most important class of beta-lactamases is the class B. The class B is the so-called metallo-beta-lactamases. These are important enzymes because against them we don't have valid treatments. You can see that in red we have the enzymes that deactivate carbapenems. Carbapenems is the far most active member of the beta-lactam family and one of the most valuable antibiotics. You can see that there are class B enzymes, some class D enzymes that you have also in India, OXA48, and also the KPC enzyme, which belongs in class A. This is very prevalent in my country. Today, we are going to speak about VIM, NDM, OXA48, and those important enzymes. As you can see in the world map, your country, among others, is marked with the dark blue because it seems that NDM is highly prevalent in these areas. My country is still in light pink or maybe light blue, but in the next years, as you will see in the data that I will present, we will for sure be dark blue as well. So the MBLs are of particular concern because they spread rapidly. We have new variants that are being isolated at a very rapid pace. They are transferable and they are ubiquitous in the nosocomial environment and in some areas of the world, like yours, also in the environmental setting, in the community. They can inactivate a wide range of beta-lactam antibiotics. We have very limited treatment options against them, and the problem for the clinicians is also the mortality risk, which is very considerable for the patient who is infected by such a producing strain. As you can see, the epidemiology data show that at least in three areas of the world, such as Asia Pacific, Africa, Middle East, and Latin America, there is a very sharply increasing trend of these enzymes, whereas Europe and North America are rather stabilized. However, they experienced a sharp rise in the previous years. As far as mortality is concerned, you can see in this slide three different areas of the world and three different time periods. The first one is a study from South Africa, when you can see this matched case control study analyzes a nosocomial outbreak of NDM1 producers, and you can see that in hospital mortality is 55% in NDM producing Enterobacterales, as compared with only 15% in non-NDM producers. And this has an adjusted odds ratio of 11.3. The second study comes from my country, and these are data from Professor Dikos. This is a study that was done in Athens metropolitan area in 2004-2005, and this was the era of the VIM enzymes. It was not yet NDM in our community. You can see that bacteremic infections of these patients with VIM-positive Klebsiella pneumonia had a 14-day mortality of 24% versus 16% in non-VIM producers, with an odds ratio also increased. And the third study comes from Japan, and we have the representative enzyme in their community, which is the IMP, MBL, and you can see again that the mortality in the population harboring the enzyme is almost 13% versus 5% in the non-producers. I will show some data that perhaps you know, some of them. This is the 5 years Indian molecular epidemiology surveillance on carbapenemase genes, and this comes from the Atlas surveillance data. You can see here the Enterobacterales in total. Enterobacterales include Klebsiella, E. coli, Enterobacter, and so on. And you can see that there is an increasing trend in NDM. It has reached 74%, but also there is a significantly high percentage of OXA48 in Enterobacterales. However, there is some kind of difference between Klebsiella and E. coli. Carbapenem-resistant Klebsiella in your community has a significant proportion of OXA48 and an almost equal proportion of NDM. On the other hand, what is the hallmark of carbapenem-resistant E. coli in your community is the NDM production. And most of the strains are carrying only the NDM enzyme, and very few of them carry the OXA48. I will show now the situation, the epidemiological situation in Greece. These are studies starting from 2018 to 2024. In the red bars, you will see the most recent study that was performed only in ICU patients. You can see that in the previous studies, we had very high percentages of KPC producers among Klebsiella carbapenem-resistant strains. However, in the last surveillance study with the red bars, you can see that KPC is decreasing, but on the other hand, MBL is on the rise, and they are almost in equal percentage now. If we present the breakdown of the MBL mechanisms, you can see that for years we had NDM, VIM, a little bit of OXA48, but now we have almost 20% of NDM and a very increasing percentage of combination of KPC plus VIM. It is important to see our antimicrobial resistance of this collection. You can see as part of this increased cohort, which was nationwide in ICU departments, that Astreonam avibactam has a susceptibility of 94.5% in those Klebsiella pneumonia carbapenem-resistant strains. And the second antibiotic was cefepime-zidovaptan, which is not available yet, and it is in phase 3 clinical trials. It is a future option. Among the other antibiotics, amikacin is less than 40%, colistin is 53%, Tigecycline, again, 54%, and cefiderocol, which is launched in Europe, but in Greece is not launched yet. It is in early access program, so it is very few cases that have received cefiderocol. The susceptibility rate is only 58%. And when we examined the strains that harbor the dual mechanism, KPC plus VIM, as you can see, the rates of resistance are worse, and still Astreonam avibactam is the most active compound against these strains with 93% susceptibility. So, as I presented previously, there is clearly an urgent unmet need and challenge in the management of infections with MBL producers due to the global spread of these enzymes, due to diagnostic limitations, and due to the complexity of treatment issues. So the challenges that we face, and maybe to some extent you face as well, has to do with the limitations of the available antibiotics. Aminoglycosides, less than 40% susceptibility in our epidemiology. We had put a lot of hope in the new aminoglycoside, plasomycin. However, it was never launched in Europe. And even with this new aminoglycoside, we saw nephrotoxicity, high resistance among NDM strains, and also resistance, inherent resistance due to some methyltransferases. Cefiderocol was also promising, but in our epidemiology, hopes are not very robust now. It has many problems reported with decreased susceptibility with NDM Enterobacterales. It has shown some heteroresistant issues, and there are a lot of issues with the microbiology testing, and which is the optimal way to test susceptibility. And also it has produced very conflicting outcomes in the clinical trials. What about colistin? As you understand, we use colistin in our settings, and colistin has a high rate of nephrotoxicity, and in the recent years, we see a lot of nephrotoxicity. There are also resistant issues. In our community, 54% susceptibility. There are also PKPD issues with poor lung penetration, and also there are issues with the microbiology lab testing, and generally it is considered as a last resort therapy. Tigecycline is a drug that we use, again, because of the microbiological results of almost 53% in our strains, susceptibility. But there are a lot of warnings for critically ill patients. It cannot be given as monotherapy. It cannot be given in bloodstream infections, in UTIs. And of course, against MBLs, there are insufficient data. Eravacycline is not available in my country. Again, it is a tetracycline derivative, so it's not recommended for BSIs and UTIs, and there are insufficient data for MBLs. And finally, fosfomycin. We use a lot of fosfomycin, and I can say that we have good results because it is a bactericidal antibiotic with very little toxicity issues. However, the literature shows that it has a high resistant potential, particularly when given as monotherapy. And there are not very good standardized combinations. Normally, we give it as a companion to colistin. What about the combination of ceftazidime avibactam plus Astreonam? I am sure that you have used it. It is a bridging drug that has helped us throughout those years. I think it was indeed life-saving for patients. However, there are some caveats in the administration of this combination. As I said, it was a bridging solution because the major caveat is that it is not PKPD optimized. There were not clinical and PKPD trials with this triple combination. In practice, there were some issues, normally outside the ICU patient, with the administration. Those two drugs should be administered concurrently, and it is not easy to do it in the medical ward and without a central line. In terms of lab testing, there is no approved in vitro susceptibility testing, so with the existing methods, we are never sure about resistance or susceptibility. And finally, we are in the era of evidence-based medicine, and we do not have clinical trials with this triple combination. So at this time point, how can we address these challenges that are presented before? First of all, I think you're very capable in this scenario. We have to identify, to correctly suspect who is the patient who has the NDM producer infection. There are some risk factors that have been identified globally, and this is travel to highly endemic areas, healthcare exposure in endemic areas, MBL outbreaks, medical tourism, prior colonization of the patient, prior antibiotic use, ICU admission and mechanical ventilation, comorbidities, and prior healthcare and long-term care exposure. In our community, the guidelines have identified the following risk factors for CRE, carbapenem-resistant Enterobacterales. Previous infection or colonization by KPC. This was the first step to have a carbapenem-resistant infection. ICU admission in the past 6 months, hospitalization in the same ward with patients carrying these microbes, plus severely ill patient, ICU or immunocompromised, and severity of the current infection, sepsis or septic shock. So the committee has argued for the use of rapid methods such as FilmArray or Carba5 as a mean to shorten the time to the identification of the pathogen and the mechanism of resistance, and to shorten the time of the empirical treatment, which is important to save the antibiotics. So in our settings, we try to adopt molecular diagnostic tests. It's not always feasible in economical terms. And there are plenty of these methods. I discussed earlier what you have in this hospital with our colleague, the head of the microbiology department. There are lateral flow assays that give results very quickly. There are syndromic assays, and there are also rapid antimicrobial susceptibility tests. These indicate the presence of carbapenemases, and most importantly, they give results on ESBLs, which are enzymes that may be hidden in every isolate that has MBL, and this is an enzyme that deactivates astreonam. However, it's not the solution for all, because rapid diagnostic tests have their own drawbacks in terms of best way of utilization, timing of the sampling from the patient, transfer of the samples to the lab, the workflow of the lab, the technicians that are needed to do the analysis. And most importantly, a big drawback of these methods is whether you have set up the correct pathway to the reporting of the results. This is very important in order to have the results directly to the prescriber. So what are we doing in my hospital? This slide presents our experience. We have weekly or bi-weekly rounds with the 3 ICU departments in which I serve as a consultant. And again, we have on-demand meetings whenever there is a problem arising. We have surveillance cultures. This is something that we started in Greek hospitals from the decade of 2000. And now we use CARBA5 for the identification of the mechanism of resistance in the surveillance cultures. Cultures are performed once in a week in tracheal aspirates and rectal swabs. Then we have a discussion about ordering a lower respiratory tract molecular rapid test. This is the BioFire test, which is not available for every patient. We have to prioritize in which patients it must be done for financial reasons. We discuss the non-significant bacterial counts that maybe do not deserve coverage, but we estimate when there is a change in the bacterial species in the surveillance cultures, because it may herald a new infection by these new species. A few months ago, we had to outsource a blood molecular testing. But now we have recently acquired MALDI-TOF in our hospital. So the time that we need in order to identify the species has decreased. An important tool in our hands is enrollment in clinical trials. And we have now in clinical trial a new microbiological tool that helps all ICU patients. This is the new BCID product, the BioFire, the new product that is called Reveal. And it shortens by almost 10 hours the work that can be done with the previous instrument. So we try to early adaptation of treatment and de-escalation, and our major challenges is the lack of the new antibiotics. In particular, ATM-AVI and cefiderocol are in an early access program. That means that we have to apply to a committee. We have to upload the patient's clinical status and particularly the culture results, and we have the right to apply only for an infection and not for a colonizer. On top of this, I would say that we have not used very extensively the combination of ceftazidime avibactam plus aztreonam, because in Europe and in Greece as well, we have a shortage of aztreonam for almost 5 years. So, are there any solutions? Yes. ATM-AVI is an important solution into this problem. Why that? Because as I explained the mechanism of resistance, you will see that aztreonam was already capable to deactivate those enzymes that cause carbapenem resistance, the NDM, the VIM, the IMP. However, if we give plain aztreonam, we risk to get it deactivated by those enzymes that are very common in these isolates. Almost every isolate that carries metallo-beta-lactamase has on top an ESBL. And aztreonam is demolished by the ESBLs. So that's why there was the bridging with avibactam. And as we know from the combination ceftazidime-avibactam, avibactam is an inhibitor that is active against class A, class C, and class D, the OXA48 type of enzymes. And as far as susceptibility is concerned, you will see that EUCAST has issued the threshold at 4 milligrams per liter and below. And this threshold, as you can see in this collection of strains with various phenotypic resistance types, you can see that this threshold is active against 99 to 100% of the collection of the isolates tested. And I will present you here something that you may be aware of. This is a poster in the previous ECMID from your country, from the Atlas surveillance program, where you can see that the prevalence of MBL, carbapenem-resistant Enterobacterales from blood cultures. In the Escherichia coli, you can see that MBL positive is at 93% and Klebsiella pneumonia at 58%. Sorry, 66% MBL positivity. And when it comes to Astreonam avibactam susceptibility, you will see that 100% of MBL positive carbapenem-resistant Klebsiella is susceptible, whereas in MBL positive Escherichia coli, the susceptibility is lower, is at 85%. And you can see that your situation is better than ours because you have tigecycline and colistin active, whereas our susceptibility is almost 50-55% in this. Maybe we are better in amikacin, but it's not the solution. Amikacin is not the solution. And as you can see in the next slide, this is the molecular analysis of those strains. You can see that carbapenem-resistant Klebsiella in your settings expresses in 53% co-production of NDM with OXA48, in 26% only OXA48, and only in 19% has a single expression of New Delhi. And what about the commonly used antibiotics? Again, 100% Astreonam avibactam susceptibility, 96% tigecycline. So the Astreonam avibactam clinical program has a preclinical phase in which the investigators exploited existing data from Astreonam and avibactam. There was also a stage of preclinical PK/PD analysis, some in vitro and in vivo and modeling data, and then it moved to a clinical phase 1 study, phase 2A study, and then 2 phase 3 studies, the revisit and the assemble. What is new with this combination that is going to be launched in a few weeks in your country? There are very significant pharmacokinetic modifications. First of all, the ratio between Astreonam and avibactam is different as compared to Casavi, and the enzyme proportion is higher with the new combination. Second, the infusion lasts 3 hours. It is recommended to be 3 hours. The dosage is every 6 hours, while previously it was given with ceftazidime every 8 hours. Those decisions were made based on simulations from phase 1 and phase 2 studies, and those simulations showed very well that the 3-hour infusion produced comparable results with the continuous infusion. You know, particularly the intensivists know very well that for beta-lactams, data from ICUs in the last decade have shown that extended infusion and continuous infusion, if possible, of beta-lactams gives the better pharmacokinetic results and achieves the so-called PTA, the probability of target attainment. So for this combination, the 3-hour infusion equals the continuous infusion, and I think it is a great property. When we had the previous combination of ceftazidime plus avibactam, it seemed that the problem is with the avibactam concentrations, And now with the new ratio, we can achieve that avibactam exceeds a certain threshold, which is called CTA, critical threshold. And with this addition, we can achieve the so-called joint PTA. The two components achieve in the same time the probability of target attainment. What about the loading dose? The loading dose is very important because with the loading dose, we can achieve the target exposures, the optimal target exposures with the first dosing interval. It is very important because, as we showed previously, the patient with a severe infection by MBL is either immunocompromised or ICU admitted. It has inherently an increased risk of adverse outcomes. And when you have the PK/PD targets attained by the first internal dose, it is the first basis to have an ultimate good outcome. In Europe, the EMA approved ATM-AVI in April 22, 2024. And as I know, in India, it was approved on March 5, 2025. The therapeutic indications in adult patients are complicated intra-abdominal infections, hospital-acquired pneumonia, including ventilator-associated pneumonia, complicated urinary tract infections, including pyelonephritis, and a general indication, treatment of infections due to aerobic gram-negative organisms in adult patients with limited treatment options. You can see the loading dose for intact renal function. It is 2 grams of aztreonam plus 0.67 grams of avibactam. And the maintenance dose is 1.5 grams of aztreonam plus 0.5 of avibactam. This is the available vial, and you have to construct the loading doses, the loading dose before administering to the patient. The infusion time is always 3 hours, and the dosing interval is every 6 hours. You can see that for, according to the type of infection, the duration may vary, and the maximum recommended duration is up to 14 days for nosocomial pneumonia or difficult to treat infections, according to the patient's status. There are some difference in the recommended dosages according to the renal function of the patient, and when the creatinine clearance is below 50, you can see that we may have a different loading dose, a different maintenance dose. The infusion time remains the same, and the dosing interval may also be bigger. So far, we have insufficient data to make those adjustments for patients undergoing renal replacement therapy other than hemodialysis. For example, the continuous veno-venous hemodifiltration. We know that for this patient, probably higher dose is recommended as compared to the ESRD category, the end-stage renal disease. Let's see the clinical development program. This is the first phase 3 study, the revisit study. In this, 422 patients with complicated intra-abdominal infection and nosocomial pneumonia caused by gram-negative bacteria were enrolled. They were randomized 2-1, aztreonam avibactam plus minus metronidazole for intra-abdominal infections, and meropenem colistin in the comparator arm. Minimal treatment duration, 5 days for intra-abdominal infections, 7 days for nosocomial pneumonia, and maximum 14 days for both. Clinical cure at at test of cure endpoint is the primary endpoint, and it was a phase 3 prospective randomized open label study. You can see that the overall clinical cure rates were similar between treatment groups in both the intent to treat population and the clinically evaluable population. And the secondary endpoint outcome, the 28-day all-cause mortality, produced similar mortality rates, which were similarly low in both arms. However, you can see there that in the microbiologically evaluable population, clinical cure rate for MBL positive patients was 50% with ATM-AVI and 0% in the comparator arm. Although the number of patients is small, you will see that this result is repeated in the second phase 3 study. The second phase 3 study is the ASSEMBLE study. All randomized patients in this study had an MBL positive, gram-negative baseline pathogen, and the distribution of the enzymes is there. Most of them were NDM. This study was prematurely terminated because of low recruitment rates, and finally it had only 15 patients, 12 in the ATM-AVI arm and 3 in the best available treatment. You can see the you can see the pathogens, Klebsiella pneumonia in the majority, and you can see that again, 42% of patients in the ATM-AVI group were cured compared to 0% in the comparator arm. So the signal is really the same between those two phase 3 trials. There are also some limitations to note that are mentioned by the EMA. The limitations have to do with the lack of vast experience with clinical trials. They had to be based on data of Astreonam alone, of pharmacokinetic analysis and simulations in both diverse infections that are given the indication, and also in the indication of infections due to difficult to treat organisms. So the limited data derive mostly from the 2 clinical trials that I presented before, and the pharmacokinetic data derive from all the preclinical and clinical program of Astreonam avibactam. And to draw once more your attention on the great advantage of the PK/PD optimization, the new combination has to offer a more than 90% joint probability of target attainment at steady state across all renal function groups. One important renal function group is the first one, the augmented renal clearance. This is a patient that very frequently you encounter in the ICU and in polytrauma situations. So you can see that with the new combination, the joint PTA is above 90%. An exception would be a patient with complicated UTI, but let's see that we are very, very happy with these PTA results in this difficult to treat population. So what gaps are filled in conclusion with Astreonam avibactam? We have the fixed dose combination in a single vial. We have made the change with the 3-hour infusion every 6 hours, which can be altered if the patient has not intact renal function. From the microbiology viewpoint, we can treat Enterobacterales, Klebsiella pneumonia, E. coli, Enterobacter, and so on. We have a UCAS breakpoint at 4. We can treat MBLs, KPC, OXA, and other CERN-based enzymes. Maybe I didn't spend time on Stenotrophomonas maltophilia because you don't have you don't have important issues in India. It can be a treatment against difficult to treat Stenotrophomonas maltophilia. The only problem is that it has now reduced activity against carbapenem-resistant Pseudomonas aeruginosa as compared to ceftazidime avibactam. And having said this, we can move to clinical cases, unless you have any questions to discuss. Should we move on? It has no activity against Acinetobacter, no activity at all. It is not in the spectrum of...
Vehicle number PG13A3097. Please contact security immediately.
Sorry. Anaerobic, that's a very good question. It doesn't have an aerobic coverage. That's why, as in the case of ceftazidime avibactam, we have to add metronidazole when we have intra-abdominal or other suspected anaerobic infections. So Acinetobacter baumannii is not in the spectrum of Streonam or avibactam. Yes, this is a particular problem that arises from your settings. This is this problematic E. coli that harbors PBP3s. And as PBP producer, it activates all beta-lactams. So against these strains, Aceronam avibactam cannot be the solution because all beta-lactam antibiotics so far are deactivated. I would suggest treatment with other class of antibiotic.
Your slide showed us Staphylococcus maltophilia.
Yes.
Is that in vitro? In vitro.
Yes.
So how do you treat that? Do you use Bactrim or?
Yes. We have a recent publication in collaboration with the Spanish Center, our ICU of my previous hospital, almost 104 patients. And we saw that 90% of the isolates were susceptible to the available antibiotics, cotrimoxazole, levofloxacin. However, the patients did not get well. It seems that we have unmet needs in case of Stenotrophomonas maltophilia. There are multiple mechanisms of resistance, and in particular, in Stenotrophomonas maltophilia, the host is very, very severely ill. It is a surrogate of a very severely ill patient, either immunocompromised or ICU admitted, immunoparalyzed maybe. That's why in many countries there is a recognized need for additional antibiotics. And in vitro data in Stenotrophomonas maltophilia showed that the addition of avibactam restores the susceptibility of Streonam in 80% of the tested strains, and they become susceptible. So it's a useful addition.
L1 serine beta-lactam is which the Stenotrophomonas which produces inherently. So that's where
Yes.
the addition of avibactam will, increase the activity of trimethoprim cells. I just have a query because this discussion was going on 2 days back. You were in the conference also. So when we are testing in terms of testing, so when we are really testing the ceftazidime avibactam and Aztreonam, because the current approved testing in this zone is disc elution, right?
Broth dilution is
I
the
mean,
is
in
the,
India, it's very difficult for us to do
yes,
FBM.
it is the reference test.
Correct.
However, it is difficult to perform in real life. So test is the proposed by the company, and there is enough evidence that it is quite
Reasonably
efficacious.
well. So one of the discussion which was brought up was when you are really testing for E. coli and Klebsiella, I mean, irrespective of the CPP3 inserts and all. So when Septorin, Avibactam, and Astinum were tested as separate molecule using the disc because that's what we are doing right now. We don't have a combination of Avibactam and Astinum right now. So we do take two separate discs and place it either as a disc
You do the plates.
Correct. Right now we are using as a disc diffusion or a
Yes.
disc elution as per the IDC guideline.
This diffusion test
Or a
is
disc
very
elution.
cumbersome if it has to be correctly done, and it's not among the recommended by the regulatory.
But right now what's recommended from the IDC is by disc elution test. I think
Yes,
the
the
recent
illusion. Yes,
test.
the
So
disc
where we
illusion test.
drop
Yes,
two discs in a
it's
single
not
test
very.
tube.
It's not very easy
Easy
to
to do.
perform. Yes.
So my question is when we are using this disc elution test, where we have to draw two separate discs because we don't have a single combination right now in India. So we have to draw two discs, one from Cephalosporin, one from the Axiom. So the discussion which was brought up on, so when Cephalosporin and Axiom were tested as two separate discs by disc elution method, you see the MIC is there versus if you use as a single Axiom combination, the MICs have been bought very low with the similar isolates with the similar mechanism.
Well, since there is no evidence documented in any publication, I could not argue on this
because
issue.
if that holds really true,
Normally, we do various things as clinicians in order to bypass the problems, but indeed, it's not something that I could argue on this.
because if that holds very true, our susceptibilities will really go high once this molecule comes in.
Yes, but when the new combination is proven more efficacious in terms of pharmacokinetics, why not use the same combination for in vitro testing?
Right.
One question from the hospital perspective. The opening slides you mentioned about surveillance cultures in your ICU once a week. Where you do your rectal swabs as well as your tracheal thing. So how do you choose patients at random in the ICU, or you do for everyone?
Every patient in the ICU has surveillance culture upon admission and then weekly thereafter. When you have the colonization of the patient, sometimes you overestimate the resistance. We found that rectal colonization is a very good predictor for BSIs, bloodstream infections. And of course, it is a great tool to make infection control job well done. Because in our hospitals, we don't have a separate box for every patient as you have in the ICU that I visited right before. And when you have an open ICU, you must have dedicated staff for the colonized patients, cohorting of this patient, and another staff for the rest of them. So when you know the colonization, you can have the infection control measures. And then you can also estimate the empirical treatment that you are going to administer when you have a septic episode.
You do that by biofire.
No, the lateral flow test, the lateral flow, which is a quick test, is performed on the surveillance cultures. Once weekly for the patients of the ICU.
Talked about surveillance for quite some time. Especially when you say remarking, we can estimate the resistance, and that can be a good indication of the escalate and response protocol.
Let's go to the cases then. First case, male, 46-year-old, with a history of very common comorbidities, plus alcoholism and schizophrenia. He was transferred in the ICU due to fever, 40 degrees Celsius, and altered level of consciousness and type 1 respiratory failure. He has increased white blood cells and some electrolyte disturbances. In the imaging, there was nothing particular. The patient was intubated and ICU transferred, and we started ceftriaxone, ampicillin, vancomycin, and acyclovir upon suspicion of encephalomyelitis, meningitis, encephalitis. When the lumbar puncture came out without findings, we stopped acyclovir and ampicillin, and the first culture of bronchial secretions in this patient showed candida. 4 days post-admission, there is a blood culture positive for Klebsiella pneumoniae and Pseudomonas aeruginosa. You can see that the first one is, the Pseudomonas is colistin susceptible. This is the pattern of the Pseudomonas in our setting. And Klebsiella is fosfomycin susceptible. The new antibiotic regimen has colistin, fosfomycin, plus meropenem, because according to our guidelines, we can never leave the patient with secondary antibiotics. Fosfomycin and colistin are considered second-line antibiotics. We need a backbone with a carbapenem. Also, intensivists gave caspofungin, which was against the consultation of the ID. The patient initially improved. The next days, the patient deteriorated with new episode of fever, increase in vasoconstrictor and oxygen needs, and then there comes the rectal swab positive for KPC, VIM, and NDM all together in the rectal swab of this newly admitted patient. This is not very common in our settings because we are supposed not having this colonization in the community. The new blood cultures show Klebsiella and Pseudomonas aeruginosa. And you can see now that Klebsiella pneumonia is the NDM positive isolate. Those isolates have a multi-drug resistant profile. Klebsiella is pan-drug resistant, and the MIC to Astreona mavibactam is 0.19. On the other hand, Pseudomonas aeruginosa is colistin susceptible, but the patient is already on colistin and develops bacteremia. And to our surprise, the MIC in Astreona mavibactam was 1. It is not anticipated that the carbapenem-resistant Pseudomonas aeruginosa is susceptible to Astreona mavibactam. In some surveillance publications, it seems that 16% is anticipated to be susceptible, in some others 5%. Our patient was at this low probability, but it was susceptible. So we maintained colistin and fosfomycin for another 2 days. We stopped meropenem and caspofungin. We add Astreona mavibactam. It comes to our hands on the 4th day from positive blood cultures, and during the next days, the patient improves clinically, vasoconstrictors were gradually withdrawn, and finally he was weaned from mechanical ventilation and discharged from the ICU to a rehabilitation center. The second case is a male 76 years old with lot of comorbidities again, and 2 types of cancer, prostate cancer, and urinary bladder carcinoma on treatment. He was transferred due to fever and productive cough. He had normal YBC count, but electrolyte disturbances, a chest CT scan with bilateral pulmonary infiltrations, rapid test for SARS-CoV-2 negative, and urine antigens negative. The patient was hospitalized and he was started ceftriaxone azithromycin as per our national community acquired pneumonia guidelines. On the next day, he spiked high fever, altered mental status, and then the antibiotic scheme was escalated to include piperacillin tazobactam plus azithromycin, and upon further deterioration, he was intubated and transferred to the ICU, where again he was put on the regimen of encephalitis because of the altered mental status, and this big regimen was withdrawn when the lumbar puncture came without findings. On the 5th day in the ICU, we have isolation of Stenotrophomonas maltophilia in the bronchial secretions. Again, it's quite short for this patient, but this was an oncology patient with previous hospitalizations. We add levofloxacin according to the antibiogram. The patient does not seem very stabilized because 1 day later he has a high fever and the blood culture comes positive for Pseudomonas aeruginosa, and then according to our pattern of susceptibilities, we add colistin. He seems quite stabilized for a few days. On the 11th day in the ICU, he has new fever, new need for vasoconstrictors, and then in the bronchial secretions, there we have the KPC plus Vim Klebsiella pneumonia. We discontinue meropenem and we start the combination of ceftazidime avibactam, I mean with astreonam, plus colistin. And then we apply to the committee to have the new combination, the astreonam avibactam. This is the susceptibility pattern of this Klebsiella pneumonia. You can see that it seems colistin sensitive, but the patient is already on colistin and is not responding. And the MIC in astreonam avibactam is 0.19. 2 days later, we have the new compound, the new combination, astreonam avibactam. And at this point, we take the decision to continue with monotherapy. Monotherapy IV plus nebulized colistin for the bronchial secretions. After 10 days of astreonam avibactam, the patient improved clinically with improved respiratory function, and in the next days he was discharged to the internal medicine ward. Do you have time to go on? Would you like to see more cases? One. Male, 70 years old, with a history of laryngeal carcinoma, urothelial carcinoma, atrial fibrillation, and so on. He was transferred to the emergency department due to fever, chills, and hypoxemia. Okay, non-significant labs, but he seems to have a urinary tract infection, and in the imaging, he has hydronephrosis with emphysematous pyelonephritis in the right kidney. Because the patient is not doing well, we opted for minimally invasive procedure, and a nephrostomy was placed in the right kidney. He was hospitalized initially in the internal medicine, and he was started on piperacillin tazobactam. Then the patient deteriorated clinically and was intubated and ICU transferred. He was in the ICU hemodynamically unstable, and the ICU physicians added tigecycline and amikacin in the antibiotic regimen. In the next 48 hours, there was no improvement, and furthermore, we have VAP in the X-ray. The cultures of bronchial secretions show now Klebsiella pneumonia NDM positive. In the regimen, we did some modification. We stop amikacin tigecycline and we start colistin fosfomycin. And as I told you, along with a carbapenem, they opted for meropenem vaborbactam because the majority of our patients have still KPC. And quite early, we apply for ATM because we have this culture in the bronchial secretions. However, to our surprise, the patient is doing well. He's gradually improving. He was extubated 5 days later, and 7 days later, he was discharged back to the internal medicine ward. We were for a very short interval, happy because 2 days in the medical ward, he develops a new fever with new hypoxia and he's intubated. And now he's in septic shock with marked leukocytosis, increased inflammatory markers. And now in the bronchial secretion, he has Pseudomonas aeruginosa, but he has also a triple culture: blood, urine from nephrostomy, and urine from the catheter that shows NDM-producing Klebsiella pneumonia. In that case, again, it seems amikacin and colistin susceptible. I would like to remind you that the patient was on colistin and amikacin previously. It seemed that he did not clear the pathogen which was initially in there. And at this time, we had already the approval. So he's put on Astreonum avibactam, and we retained colistin due to the Pseudomonas this time. The duration treatment was 14 days, and in parallel, we replaced the nephrostomy, and the patient gradually improved and was discharged in the medical ward. Any comments, any questions? Would you do differently?
Probably the second case where for the Klebsiella, there's only KPC and Vim. Generally, Ashwin is recommended for NDM. Probably in your second case, there's only KPC and Vim and there's no NDM. So we would be slightly comfortable in just continuing the ceftazimab alone rather than without an Ashwin because there's no.
Who you did? What?
Ceftazimab alone without combining an Ashwin.
But it had Vim. Ceftazidimab avibactam is not active against Vim.
Correct. And even the probably when you're doing colistin plus phospho and Ashwin avibactam, when the Pseudomonas was there, so we all had phospho. So we would be comfortable in stopping phosphomycin as well in that case. We would have continued only Ashwin avibactam plus colistin in the backbone. Right.
Mainly in liver transplant patients where hepatotoxicity is one of the side effects of this combination. How frequently you have seen any case with hepatotoxicity of this drug?
Well, in my institution, we don't have a transplant program. However, we occasionally admit patients from other hospitals that do not have ICU beds. So we don't have an abundance of this type of patient. One of the last cases was a SOT patient with a kidney transplant, but he was not in the ICU. He was a ward-admitted patient, and he had a paranephric effusion that was contaminated by an NDM, positive Klebsiella, and he received 10 days of Astreonum avibactam and went quite well. This is the only example that I have with SOT patient.
So when the patient is having only NDM, compared to the patients who have both NDM and other serine proteinases, those patients who have combination of resistance will recover better. Will have like a response will be better with the combination of resistance. That's what they tell. What is your take on that?
You mean when there is the dual enzyme?
Type of resistance, yeah.
The number of patients that we have treated does not allow us for solid conclusions. Those things are going to be shown in observational trials that are going to be done once the drug will be launched. I showed one of them he had a double mechanism of resistance and did well. However, we do not have international evidence or any publications yet on the issue. What I showed previously is that in vitro, there is a great difficulty to find an active compound against double mechanisms. These were the microbiology data, but in the clinical grounds, we don't know whether it would be difficult to treat.
Yeah, and the other thing is, I think we were very kind in allowing the name of New Delhi Metal Activities because we were talking a lot on this MBL and India, unlike China and Wuhan virus. And one question I was seeing as a snapshot of the current resistance in Greece,
Yes.
which you are having, because we were in that situation probably 8 or 9 years ago. So where our Indium was creeping up 8 or 9 years ago. So I just wanted to ask in your E. coli and Klebsiella isolates, where right now you're probably seeing the Indium going up. When these isolates were sequenced, did you notice any PB3 inserts as well? Because
No, not yet. PB3
Not yet.
is not. Is not.
Probably that's a good situation. Which
Yes.
you're dealing with. And one other thing, because you're seeing a lot of inpatient, outpatient care. So when you shift to this new molecule, which is probably 4 times a day and 3 hours infusion, which has to be kept. So when you're dealing as an OPAT therapy, outpatient antibiotic therapy, so when we are shifting the patient on ceftriaxone probably for 5 days or 7 days at home, because that is commonly done in Indian practice as an OPAT. So how is the acceptance rate for your patients? Because right now
Well,
we give it 3 times a day and probably 2 hours. So the patient has to be on the infusion.
I
probably
understand
for
the
6 hours.
question. In my country, OPAT is not very popular and well organized. And actually, we can do OPAT for antibiotics that are given maximum twice daily
Okay.
because of our infrastructure. I think that this drug is not a good candidate for OPAT, given the fact that we need to have 3-hour infusions and it is difficult to be achieved at home care or even with visits in the hospital. On the other hand, I think that in our settings, the patient who suffers from such an infection is not at all candidate for OPAT treatment.
Because in our settings where, I mean, let's say they have any osteomyelitis because of
Yes.
CRTP.
I thought of this,
If they
yes.
have probably spondylolisthesis
Yes.
secondary, where they need probably around 4 to 6 weeks of treatment. Because there are a good number of patients which we deal in such format as an OPAT therapy, because cost is always an issue in Indian context. So good number of times we transition them to ceftriaxone and your TG is gone, your fosfomycin is gone. We are ultimately left with either casomycin or colistin. And of course, we go for colistin. I mean, casomycin over colistin because of adverse effect. And then
It's a different profile of patients,
Correct,
of course. Yes,
but
I
now with
agree.
this thing, they have to be probably 12 hours on the infusion per day when they are reaching home. So that might be one of the concerns which we might face practically.
I think we are done. You want the conclusions? No. So, just to summarize, in this difficult to treat situation of MBLs, Aztreonam avibactam has the potential to address important unmet medical needs. It provides a treatment with favorable effectiveness profile for these MDR infections. It addresses the global antimicrobial resistant crisis. It provides also an optimized PKPD, which is very important for the critically ill and ICU patients. and it has a favorable safety profile, as we know from previous studies, either alone or with the new combination. Thank you very much.
Thank you, Professor. It was an excellent presentation.